As you all know, our nationally accredited Emergency Management and Homeland Security program touches all public safety resource, response disciplines, and emergency support functions. We as a nation and as a state are actively battling the current opioid crisis and want to present important information to our partners today. Last Friday, when announcing a $5.5 million grant to expand the state's effort to combat this crisis, Governor Malloy said, and I quote, "Our work on this front will never be finished until our communities and our families are no longer struggling with the grave costs of this illness." Here is an overview of the efforts of the opioid crisis and response in Connecticut from the Department of Public Health, Rafaela Kohler, Director of Office of Emergency Medical Services, followed by Peter Canning, RN, paramedic, Yukon EMS coordinator.
Good morning, everyone. I want to thank you for inviting us and allowing us to share with you some of the work that we're doing in regards to the EMS role in the opioid epidemic that we're facing in the state of Connecticut. I'm just getting a little technical help here since I don't know how to use this. And because I'm so tall, this has to be raised. Green, okay. All right, thank you. So Peter and I have been working together for about 25 years. We met initially when I was doing an instructor course for EMTI. Is it over 25 years ago? Long, okay, we won't say longer. About 25 years, and there's always a contrast between our height, so we like to stand together so that people can recognize that. And we continue to do work, and this is a great opportunity for us to, again, come together and look at the EMS role as in the opioid epidemic. So what is the role? What is our goal? So our goal is pretty simple. It's just to improve the quality of emergency pre-hospital care as it's delivered to patients with opioid and substance abuse and addiction. And you may say, well, that's already covered in a lot of the text that we have, but I think there's missing points that are not there, and we might have the medical terminology of knowing that, you know, an overdose has decreased breathing, and when we get there, we're going to administer Narcan. But I think there's a lot behind the scenes that we don't know about, and that is the disease process itself, and that the fact that it is a disease, I'm very, very happy to hear that people are recognizing it as an illness and not a drug choice or something that always has had a stigma, and Peter will talk a little bit more about that as he gives you what our program is going to entail for the EMS pre-hospital personnel. Okay, so you know that emergency medical services personnel are really the first witness to this battle, and they do this on a daily basis. They're vital partners. However, I think we've missed a great opportunity in having them help us to combat the epidemic. While they provide, you know, life-saving emergency treatment such as Narcan, they can also make a substantial contribution of education, prevention, and data collection. And these are some of the EMS roles that we have identified for EMS providers. So looking at the leadership, looking at data collection, looking at what we can do to improve the emergency treatment, what educational resources can we develop to both the provider who's there and also the family members, and then looking at prevention interventions. And these are some of the things that we have looked at. We have worked with partners. We looked at the opioid overdose working groups, and I know that Peter is a member on many of these groups as they meet on a monthly basis to look at data and to look at hotspots and to look at what we can do for interventions. We've partnered with the EMS regional councils. There's 5 regional councils in the EMS arena, and as we develop educational materials, we're going to look to them to be the distributor and the holder of those materials, so that we can reach every region, and then look at the service organizations and what they can do to help us. The partnerships also know that we are meeting the core objectives with the governor's initiative, and also meeting some of the preventative health and health services block grant, which this year, if we are awarded that, will go towards the opioid crisis in EMS, not in EMS, but helping with the role of EMS. All right. So these are some of the initiatives that we're talking about in the intervention and prevention, talking about developing informational packages, talking about looking at our protocols for the naloxone on scene. And I have a picture later on to show you that we have already made changes to our protocols that were released as July 1st. As new data has been available and new materials are available, we are making constant changes to those. And then creating a system to follow up with visits and community together. So it's about partnerships, it's about education, and those are the two things that I think EMS can play a bigger role than we are presently playing. Right? So some of the initiative is that the protocols were changed to allow for the 4 milligrams of naloxone intranasal. Prior to that, it was 1 milligram in each nostril, intranasal, and there's a new pharmaceutical company that came out with a one-time dose, 4 milligrams, and we have updated our protocols. We're looking and working with partnerships to improve what our EMS systems data collection. We at OEMS have the data for the pre-hospital personnel, but we don't always have the data that other people have seen. And so we want to have an ability to aggregate that data and have a clearer picture, because we don't have a picture of all that's going on in the state. Then develop educational materials for EMS providers. And I was watching CNN last night, and Paul Cusick, Governor Cusick from Ohio, was one of the speakers, and he was talking about the educational materials. Ohio has a very high incidence of opioid overdoses, and he was talking about, most people will develop materials, and I was thinking about this today, and we will. We always think about pamphlets, or we think about handouts or something, and he said people don't read that stuff. What they read is their phone, what they read is their apps, and that maybe we should cross that and develop even more, think out of the box and be a little bit more innovative in developing the educational materials that we're looking for. And we also want to be able to leave some of those materials at the patient's home. So 911 is called, EMS responds, they take care of the patient, but there's a golden opportunity there to educate the patient's family. And usually there's a first responder, there's a transport, so the transport leave, but the first responders can be on scene. And so one of the things that we would like to do is utilize that first responder to be able to educate patient's family, or maybe even educate them on the use of Narcan and leave a naloxone kit at the patient's home. Okay. Here's the intranasal naloxone that I spoke about. And obviously with the education, we also don't want to forget that we want to emphasize the airway management in our training program. So most people are dying because they have a respiratory depression, and we have to maintain that respiratory rate. Naloxone turns around the drug but does not necessarily maintain the airway. So we want to be able to make sure that people remember that and are addressing that in their treatment plan. So some of the ideas that we have is to do a 1-hour instructional PowerPoint, and that we would put this on the Connecticut train. It would be available to anyone at any time. They can do that, and they can use it as CEUs. They can use it as just as an educational model or continuing education for their own services. The other is that we will be presenting a summit in September 2017 with the endorsement of the Yukon. So that would be something that we're all looking forward to doing and unveiling all of our work. And then there is more on the education and prevention that we're talking about. And what to follow is that Peter is going to give you a sample of what the EMS training program would look like, what it includes, how he's going to explain to you our prevention initiatives, and then give you an early warning systems concept. So this was an introduction. Peter's going to go directly into what the educational program would look like. Thank you.
Thanks, Ralph.
Do I have to stand?
Sure. All right. Okay. So the governor's core initiatives had a number of different strategies that the state needed to take. One of the main strategies was to work to decrease the stigma of opiate use. This was a Facebook post that came out of Massachusetts a year or so ago, in which a firefighter railed against having to use Narcan. Now, his department obviously said these are not the values that we have, and they're not the values that most of us in EMS have. However, as somebody who's been taking care of opiate overdoses for over 25 years, I can tell you when I started, and when I took care of somebody, while I treated them well and with kindness, my view of them was that this was a character flaw, that this was something aberrant that they did that they could correct if only they wanted to. It's very important for us to understand how this epidemic started and what's actually going on. A number of years ago, Purdue Pharmaceuticals, who made oxycodone, their sales force went out and they told people and they told doctors that oxycodone was not addictive. They told them that when used properly, that it did not produce a high and that users could not build up a tolerance to it. Doctors, in turn, started prescribing it very generously. Groups such as the American Pain Society argued that it was very wrong to keep people in pain. Pain became the fifth vital sign. Unbeknownst to many, all these pain societies were largely funded by the pharmaceutical industry. Now, as a lot of pills went out into the street and into the black market, while the DEA was working hard to get these pills off the street, another branch of the DEA was approving, at the pharmaceutical companies' request, massive increases in the production of oxycodone. From 2012 to 2013, the DEA approved the increase of over 50 million kilograms of oxycodone. At the same time, the death rate was skyrocketing. Now, what happened to these pills? They got out into the street and into the black market. Today, more Americans are on prescription painkillers than use tobacco products. In Connecticut in 2002, there were 72 painkiller prescriptions for every 100 people in the state. Other states such as Alabama and Tennessee had 149 prescriptions per 100 people. So what happens? A lot of people get addicted. Not everybody. Some are more genetically disposed to it. As they take the pills that are prescribed by their doctors, their body builds up a tolerance. In time, their tolerance often outruns their prescription, and they're left to turn to the black market to get their pills. A 30 milligram oxycodone costs $30. At the same time today, in the city of Hartford, a single bag of heroin, $4 if you're a pretty girl, $5 if you're a dude. If you're buying massive quantities, if you're buying by 100, you can get it for as low as $1.70 a bag. So, and it works just the same, and many people think it works quite better. People who are addicted to prescription pain meds are 40 times more likely to become addicted to heroin than others. So I want to tell you a story now. This could happen in any town. Picture your high school. It's Friday night, the football game. You have a full crowd there. It's halftime. The home team leads by a touchdown. The cheerleaders are rallying the crowd. Their proud parents are in the stands. Two cheerleaders are thrown high into the air. They reach the top of that throw, and they are at the pinnacle of their lives. The first cheerleader comes down. She's caught. The second leader comes down. She's dropped. There's silence in the crowd. Her parents come down. They rush down from the stands. The girl lies there. Daddy, Daddy, my back is killing me. They call EMS. The paramedics get there. They feel her back. They feel crepitus. They put a cervical collar on her neck. They put her onto the ambulance. They drive to the hospital without lights and sirens. We don't use lights and sirens unless it's a matter of life and death. Unbeknownst to anybody here, she started on a journey that could prove fatal to her. Her doctor, after her surgery, prescribes her a 6-month supply of Percocet. She takes it for the pain. It makes her feel better. In time, she outruns her prescription. her doctor cuts her off, or only gives her enough that doesn't take care of her pain. So she turns to friends. She buys Percocets for $30. It becomes a bit of an economic problem after a while. The same person selling her Percocet can sell her heroin for $4 a bag. She says, I don't want to put a needle in my arm. He says, you don't need to. It's a fine powder. You can just sniff it. She tries it. It feels just like Percocet, only better. A few months later, we get a call for a woman for a car into a pole. Find a female passed out behind the wheel, not breathing. Pull her out of the car, start breathing with an ambu bag, give her some Narcan. We revive her. Talk to her. What happened? Did you use heroin? No, I didn't use anything. No, actually, you probably did because we gave you Narcan. She starts crying. My parents are going to be so upset. I've disappointed them. She's been in and out of rehab. She was doing very well, and then she's relapsed again. What could have happened to her? Cheerleader number one was caught. Her dreams, a home with a white picket fence, a marriage, a nice family. The other girl now, all her dreams are going into a hole in her arm. Whose fault was that? Was that a character flaw of hers in the beginning? It's a big, big problem in this country, and it's happening all over. It's happening all over. So what happens with the opiate disorder? When she first takes that opiate, one center of the brain feels enormous pleasure. Shortly after, another center starts to feel that pleasure sipping away. Then the third center of the brain says, I need to get some more. In time, this cycle spins up. The pleasure center decreases, and the anticipation, the compulsiveness, I need to get more, takes over. And what this does is this creates a circuit in the brain. This becomes a brain disease, where most people, for survival, were programmed for sex and for food. For opiate users, their brain is rewired that they need heroin or they need the opiate for their survival. That's why you see parents shooting up in front of their kids or addicts stealing in front of police officers. All they can think about is they need that to survive. Even after they get clean, they go through withdrawal, they come out of treatment, there's nothing in their system anymore. That circuit is still in their brain. They're still fighting every day. Their brain is saying, you need an opiate, you need an opiate. That's why the relapse rates are so high. So you can take this girl, you can put her in an MRI, and you can look at her brain, and you can see her brain is damaged. And to expect her to think rationally would be the same as expecting someone with heart disease or COPD to climb Mount Everest. The same way you put the person with heart in the machine, you can see it's damaged. Now, fortunately, over time, some people, not all of them, can get better. Their brain over time can heal a bit, and that's what we hope to have happen to everybody. Not everyone is going to make it, but certainly there is possibility of recovery for many. So years ago, when I took care of a heroin addict, I would say to them, listen, you're going to die. Just say no. Stop doing this. You know, you're crazy. You're killing yourself. Now there's something called harm reduction. And harm reduction accepts that people are going to be using drugs. So if they are, let's try to mitigate the effects of that. Needle exchange, community Narcan, and straight talk is what harm reduction is about. You can't cure somebody if they're dead. So now what I do is I say to somebody, listen, if you're not ready for treatment, what you need to do is you need to make certain you have Narcan available in your house or nearby you. Don't use heroin alone. Have somebody with you. If you're buying from a new source, don't do the usual amount that you normally do. If you're just out of jail, if you're just out of rehab, or if you've tried to go easy for a while yourself, just do a little bit of a tester shot. You can always get more. So this is there was a triple overdose in Hartford. And what the Hartford police did is they put in the paper pictures of the bags that were found on the scene. So in the East Coast, a lot of the heroin is sold in these glassine envelopes. And some of them have a stamp on it, which is the dealer's brand. Some of them are blank, but a good proportion have the brand. So this was in the Hartford Current. A number of weeks later, I picked up somebody out of the Hartford jail, was going through withdrawal and wanted to go to the hospital. And I asked him, you know, were you aware of this triple overdose? And he goes, you know, he lived in Windsor. He drove down to Hartford to buy the stuff himself. Nobody knew he was a user. He goes home after buying some. He picks up his dad's paper and goes into the bathroom and reads it. And he sees that article. And he goes, my goodness, that RR there, which is some kind of Australian blue jeans, I just bought that brand. I have that brand. So when he goes into his room and locks the door, instead of doing the 5 bags that he normally does, he does 1 bag. He wakes up the next day with a needle still in his arm, but he's alive. His parents didn't have to knock down the door and find him dead. Not only is he alive, but he's ecstatic because he still has 4 bags of heroin left. This is just an example of some of the brands that have been found in Hartford recently. All right, so one of the initiatives that we're working on is when EMS, we're going to do this as a pilot in one of our cities, when they respond to an opiate call, they're going to call poison control. We've met with poison control. They're excited about this. And they'll report about the encounter. Was the person an overdose? Was it a heroin addict where they were just able to shake them and get them back? Did they give them Narcan? Where was their home address? Where was the incident address? And was one of these bags found on the scene? And so right now, the only data we have death data and we have Narcan data, but the Narcan data is not always a proper surrogate for the number of overdoses. So we're hoping that this will allow us a real-time surveillance. If suddenly, and Kelsey and Bob are going to talk about this in a minute, if a drug called carfentanil comes, which is used as a tranquilizer for elephants, if that shows up in Hartford, hopefully with a system like this, suddenly there's a rash of overdoses, we're going to know in real time, and then we can direct resources to both public safety and to the community organizations to try to deal with it. Here's an example of the Narcan data. Hartford AMR tracks Narcan and puts it on a heat map so they can identify the areas where most of the overdoses are. So I just want to close with talking about this. This is a real case. Upon arrival, a 24-year-old male found unresponsive lying on the floor, his mother performing CPR on him. She last saw him alive an hour before. Now, keep in mind, 52,000 people died of overdoses in America last year. Over 900 did in Connecticut. That means today, 3 people are going to die. Some will be found by their parents, some will be found in motels or in cars. This person was revived by EMS, but unfortunately died in the ICU. So how could we prevent this from happening in the future? This person had called 911 before. When EMS goes, we can talk to the family. You really need to have Narcan here. Well, but my son's been in treatment. He's clean. But it doesn't matter. You need to have it in your house. If they don't have insurance, we could hook them up with a community group to help them get insurance. You know, we could give a talk on using safely. We're not going to save everybody, but every life that we save is a life worth saving. So in conclusion, this is from the Facing Addiction in America, a report from the Surgeon General. And it's how we respond to this crisis is a moral test for America. Are we as a nation willing to take on the epidemic that is causing great human suffering and economic loss? Are we able to live up to that most fundamental obligation we have as human beings to care for one another?